Good afternoon, good morning, good afternoon, good evening, and welcome to this webinar session on gender considerations in COVID-19 vaccine rollout. Thank you very much for joining us today. We're happy, and sorry about the little delay. We had a little technical issue to launch the recording. Which means that this session is recorded, and which means that we're going to share the links to the recording in French and English by email, as well as the link to the presentation in English. This session is interpreted into French. I'm going to say that in French for our francophone colleagues. Cette session est disponible en français avec interprétation. Vous pouvez accéder à l'interprétation en cliquant en bas de la fenêtre Zoom sur le globe et choisissez interprétation et français. Please don't hesitate to ask your questions during the presentation in the Q&A box. You can use the chat to introduce yourself and if you cannot find the Q&A box, you can use the chat for the questions, but please preferably use the Q&A box. I will let Stephanie introduce herself, and Stephanie Shendale from the WHO. Stephanie, the floor is yours.
Thank you, Alex, and hello, everybody. My name is Stephanie Shendale. I'm a technical officer with WHO headquarters in Geneva, the Department of Immunization, Vaccines, and Biologicals in the Essential Program on Immunization's Life Course and Integration team. And yeah, I'm very happy to be here today and to kick off this session with a short presentation, and then we'll get into some more interesting regional and country perspectives with our second and third presenters. So in the interest of time, let's get going. Alex, can you project the slides, please? Okay, great. It's just the title slide, so let's continue. Here's just a brief outline of what I'm going to try to run through in my 10 minutes today. So apologies in advance, it will be very brief, but these slides will be shared and available afterwards for further reading. So let's get going. Next slide, please. So just because I'm not sure, about the audience that we have today and how familiar everybody is with these concepts, so I just wanted to cover quickly an overview of the differences between sex and gender. So when we talk about sex, we're talking about the biological and physiological facts of being either male or female. But when we talk about gender, we're talking about the social constructs, the norms, roles, responsibilities, behaviors that are assigned to men and women. And also this means their interactions and relationship with each other as well. So these are different concepts and they have different implications. And today we're going to focus on the gender considerations for COVID-19 vaccine rollout. And so just to keep in mind that we're talking about the social norms, roles, and responsibilities that are felt differently by men and women. Next slide, please. And so as a result of both sex and gender, men and women have very different experiences in health status, exposure to risk, susceptibility, vulnerability, access to and use of services, health-seeking behavior, experiences in the healthcare settings, and health, social, and economic outcomes. And this is across the board, not only related to COVID-19, but of course, that's the topic of the presentation today. But just to highlight that this is this goes broader for all health services, including immunization, not just for COVID-19 vaccine. Next slide, please. So different gender impacts or experiences with COVID-19. And from very early on in the pandemic, it was recognized that men and women were experiencing COVID-19 differently. Some of this is a result of behavior changes or differences between the genders. So for example, men smoke more, less likely to comply with non-pharmaceutical protective interventions, potentially less health-seeking behavior, and then delay seeking care when ill. And on the flip side, exposure and vulnerability differs between genders as well. So in many settings, Women are the primary caregivers, and in some cases, the majority of frontline health workers are female. And so therefore, exposure to the SARS-CoV-2 virus was higher amongst female populations. We noticed differences in the way that PPE was designed and able to fit females, for example. This is just a heading from an article in The Guardian. And so there are a lot of differences in how COVID-19 has hit and impacted an individual based on their gender. Next slide, please. So now that we are well into the vaccine era of COVID-19, what does the global data show? So this is data from a couple of weeks ago. We'll have some new data this week. This comes in every 2 weeks. And this just shows the gender disaggregated coverage amongst the WHO member states that are reporting to WHO. Now, one thing to note right away is that this is only from 84 countries. We don't have a very comprehensive picture of what's going on globally in terms of gender disaggregated coverage. We only have 84 member states reporting this regularly, and so this is a huge gap. You can see, though, from this data, it doesn't look like there's a very big discrepancy in coverage. The ratio of primary series completion amongst females versus male populations is only 51 to 49, so that looks about equal. But as I said, this is only 84 member states representing only 38% of the global population of WHO member states. So this is very, very limited. And that's a huge gap that we really need to encourage better reporting of this kind of data so that we can see what's going on. Next slide, please. The other major thing that this global figure masks is actual differences across countries and within countries. So when you look at these 84 member states individually, you can actually see that there is a bit more variation across the board. This shows a difference in percentages between coverage of males versus females. And you can see that we have some countries up to 12% difference, and then up to 15% difference on the other end of the spectrum. And it varies a lot. And it also varies a lot within countries. So what we don't really know is what's going on subnationally or in some communities where there might actually be a much bigger differential between coverage amongst males and females. The other thing that this data doesn't really show is the demographic differences in some of the target populations that we're looking at. So amongst these countries, a lot of the coverage itself is still very, very low with COVID-19 vaccine. And so what we might be seeing in this data is really reflective of the initial target populations that were being rolled out. So for example, in countries where healthcare workers are one of the primary target groups, and they are predominantly female, or in some cases predominantly male, that might be skewing the numbers that we're seeing right now because those target populations actually have a specific demographic. In some countries, we know that they've targeted, for example, their military early on in the COVID-19 rollout. And so if those are predominantly male populations, then that will be skewing. So what this doesn't really show is necessarily how gender equitable the general population vaccine rollout is in a lot of cases. So we need more data. And then the last point I'll say on the data piece is that, like with routine immunization, what we know is that, in fact, many of the gender-related barriers in access to immunization services are being felt and are more greatly impacting those populations that are actually not being vaccinated at all. So it's the missing data where a lot of these missing communities that are really where some of these issues are actually the greatest. Next slide, please. And so just a quick opener on gender-related barriers for immunization in general. So gender-related barriers operate at multiple levels. We're talking from individual all the way up to community and health system level. And they're really underpinned by power relations. And unfortunately, this leads to very different outcomes, especially for girls and women. And then the other thing to highlight is that gender-related barriers impact both the supply and the demand sides of immunization. So gender-related barriers can impact how individuals access services from the provision of services side, and also very much so the health-seeking behavior, so the demand side of immunization. Next slide, please. So just some examples, and I'm going to go through this quickly because we're going to get into more of this detail in the subsequent presentations. But these are some of the common supply side barriers that can impact immunization service access. And this is, again, not specific to COVID-19, but obviously very important to take into account in the rollout of this particular vaccine. So we know that in some places there's a cultural preference for female vaccinators. Sometimes poor quality of services or negative attitudes can impact particularly women wanting to seek services. There are poor conditions in some cases for women, limited representation of women in managerial and decision-making positions, which all sort of impact how women interact with the healthcare system. Next slide, please. And then just a few examples of the demand side barriers that we might be dealing with. In some cases, in some communities, women may have limited decision-making autonomy or lack of control over the resources in the households to be able to actually go out and seek health services. There may be mobility restrictions that are particularly impacting females and their ability to travel outside the home. Lower education and health literacy levels can impact how health information is actually reaching some of these communities and the ability of women to make decisions for themselves on how and when to seek services. And then, of course, gender-based violence and harmful practices can also really limit a woman's ability to actually have her own initiatives to be able to reach the health services. So these are just a few examples. Next slide, please. And so, of course, the important thing is to be able to identify whether these barriers are existing in your countries, in your programs, and then, of course, to be able to design and tailor solutions to address them. And so really, again, the importance of collecting this kind of data cannot be emphasized greatly enough. And this goes beyond administrative data that shows coverage levels, because as I explained, sometimes that's not actually giving the entire picture. But of course, that's a start. So sex disaggregated coverage can flag whether some of these issues are happening in some of your communities. But of course, there's a whole other range of tools that can be employed to try to get down into some of the more detailed reasons that gender-related barriers might be impacting access and coverage to services. Next slide, please. And so this is just, another few examples of some of the potential barriers. These are commonly identified barriers that are faced by women in some settings, and then a few relatively simple solutions that can be implemented to address these specific barriers and hopefully improve the access and uptake of services. So, as I mentioned before, in cases where women might have limited mobility, time, and mobile access, you can design solutions to bring the vaccines closer to them, consider extending hours, gender dynamics in decision-making, cultural preference for female healthcare workers, if possible, to increase the number of female vaccinators, provide women-only vaccination sites. I know a lot of this is easier said than done. It's not to say that this is simple, but just to show that there are gender responsive solutions that can be put into place once you've identified that some of these barriers exist. Next slide, please. And so last year, this excellent checklist was published by the Gender Equality Working Group in partnership with the Gender and Health Hub. So it was a very cross-organizational effort, and it is specific to COVID-19 vaccine deployment. It outlines some practical actions for countries to take from end to end along the vaccine deployment process. And so it's available at this link. If you haven't seen it before, I really encourage you to go out to visit it. And along each of these steps of the process, there are lists of common barriers and potential solutions to consider when rolling out COVID-19 vaccine to ensure a more equitable and a more gender equitable deployment, obviously with the objective of reaching everybody across the entire target populations. Next slide, please. One other resource that I just want to highlight as well, this is relatively new also. This is a joint publication, WHO, UNICEF, and Gavi partnered to publish this guide, Why Gender Matters for Immunization specifically. And so this is not specific to COVID-19, but of course, all of the concepts apply. And it also has a lot of really good information on very commonly observed gender-related barriers to immunization, common solutions that can be applied to respond to these, and also links to other resources and tools for both data collection and gender responsive programming. Next slide, please. And then just the last set of resources that I really want to highlight. Again, the first two on the far left are new. The other two are a little bit older, so you might already be aware of them. But these tools are really helpful resources to understand and address behavioral and social drivers of vaccination. And this is for both routine immunization and also for COVID-19 rollout. The behavioral and social drivers of vaccination tools are questionnaires that can be applied to get at the root cause of some of these problems, and then position you and your programs better to design tailored responses to them. And so those are available at that link. Next slide, please. And so then just in summary, of course, it's very important to think about gender during the vaccine rollout for COVID-19 for very many reasons, of course. And then the other thing to remember is that applying a gender lens to COVID-19 vaccination can inform and build capacities for routine immunization as well, and vice versa. A lot of these issues that may be being faced by communities for COVID-19 are also probably impacting ability to access routine immunization services. So thinking about it this way when doing your RI programming as well is a really important shift that we really want to encourage. Quality data analysis, can't underscore that enough. It's really needed to be able to tailor the appropriate responses, and of course, resources are available to help. I have one more slide that you'll have in the deck with a whole other list of further reading, but I won't go through it now. So next slide, please. That's all from me, I think, yes. And without further ado, I will hand it over to the next presenter, Sofia de Almeida from UNICEF ESARO. Sofia, over to you.
Thank you very much, Stephanie. Thank you all. Very quick presentation. I'm Sofia de Almeida, Social and Behavior Change Specialist from UNICEF Eastern and Southern Africa, the regional office. And I'm also coordinating the Regional Technical Working Group on demand for COVID-19 vaccines. As I'm on mission to ensure a better connection, I will suggest to put my video off while I'm presenting to ensure a better, a stable connection. Thank you very much. Next slide, please. So I will present some of the work across Eastern and Southern African countries on gender and immunization with reference to COVID-19 vaccination. This first slide shows uptake of women in Eastern and Southern African countries reporting disaggregated data, as also mentioned by Stephanie. According to WHO Afro Dashboard in July 2021, women represented only 27% of the vaccines administered. However, only 11 countries out of the 18 countries that were introducing COVID-19 vaccine at that time were reporting disaggregated data by gender. In June this month, 2022, data shows some considerable improvements, but again, where data is available. So there is a huge gap on disaggregated data, but women so far represent 43% of doses administered in 11 countries as a region. And the reasons for the significant disparity were various. So limited disaggregated data, timely reported, unequal uptake of COVID-19 vaccines, and several access-related challenges to get the vaccine. Next slide, please. So data collection efforts have been made to identify barriers and challenges hampering the uptake of women in the region, and to use this evidence to inform planning. From data collected, we confirm that women face several challenges during the journey to get vaccinated. Women experienced massive secondary effects of the COVID-19 pandemic in different areas, including job loss, income drop, or gender-based violence, and that reduced their ability to complete their vaccination. Additionally, women reported sexual and reproductive health care disruptions at significantly higher levels. And evidence shows that in some Eastern and Southern African countries, more women reported challenges on accessing vaccines when comparing to men. And although women in some countries have a higher risk perception of COVID-19 than men, they have lower levels of acceptance of the vaccine. They have more questions and specific concerns about COVID-19 vaccines that are fueled by misinformation, and that needs to be addressed and clarified to activate intention to get the vaccine. Next slide, please. This slide shows several challenges faced by women in each phase of the journey to health and immunization. So finding from different sources highlighted concerns and questions related to the first step, the knowledge and awareness. Many concerns around pregnancy, fertility, or breastfeeding. And this has been shown by social and behavioral data across Eastern and Southern African countries, as well as by digital social listening. And these concerns, fears, and questions that are fueled by misinformation circulating among communities and through social media affect how women think and feel about COVID-19 vaccines, and also affect their intention, their willingness to get the vaccine displayed here on the step 2. And even when women show higher levels of vaccine confidence in general, data shows that they are more skeptical when it comes to a COVID-19 vaccine, at least in 5 ESA countries. Analysis of social and behavioral surveys among general population and health workers shows that women have lower levels of trust and confidence on vaccine when comparing to men. They have also less willingness to recommend the vaccine, less perception that their communities and co-workers will get the vaccine, and also slightly less intention in some countries. And finally, they have reported less easy access to COVID-19 vaccines. Moving to the third phase of the journey to health and immunization, we identify several barriers faced by women when they try to access immunization services, from the socioeconomic impact of the pandemic to access related challenges. And this includes lack of time due to domestic responsibilities, women that are unable to walk long distances to the vaccination site. Some are willing to get the vaccine but don't have transport money to go to the vaccination site. And they also have limited knowledge about vaccination sites close to their areas. At the point of service, the healthcare services have been disrupted. And when women access the service, they can face challenging experiences. I reflected on the step 5, such as long queues and lack of organization. Some goes to vaccination site expecting some clarification to take informed decision, and some can turn around without being vaccinated for several reasons, such as limited information, unavailability of vaccines were also reported, or long time waiting. And after the service, there is a need to continue monitoring the situation. Next slide. So what can be done to address those challenges? We have been providing a set of programmatic recommendations based on evidence that have been implemented in the region. Trust in vaccines, trust in services, in different actors can play an important role on addressing and on accessing immunization services. That's why it's so important to invest in trust-building interventions by providing safe space for discussions with experts and facilitate community-led conversations to clarify questions on vaccine safety, efficacy, AEFIs, and to address concerns and perceptions and reinforce trust in vaccines. Also amplify new evidence as it becomes available. The situation is very dynamic, and it's very important to use fact-based information and also fight message fatigue to dispel myths and misinformation. Engage with key stakeholders, as men play an important role in decision-making about vaccines for women. and their participation may also be essential to making sure women can access immunization services. It's also important to publicize the prevailing social and work norm by showcasing female key influencers, peer influencers, religious and community leaders, and female health workers getting the vaccine, as well as positive women interest stories. But partnerships can also play an important role, not only to build trust and increase positive social norms, but they can also play an important role on improving access. So partnering with women organizations and faith-based organizations and other community-based groups, it's important to ensure that gender perspectives are considered in planning, including micro-planning on designing and monitoring, as well as improving access to vaccines. So what we need to consider to improve points of service is to adapt services to women needs, which means with consideration to local dynamics, increase the number of vaccinators, female mobilizers, and sites for vaccination. We also need to consider deploy community mobilizers to areas with low immunization rates, particularly in settings where facility-based health services are not easily accessible areas. Considering delivering vaccination services in places where women congregate, for example, markets or churches or mosques, workplaces. But it's also important to have in mind that outreach, it's not the only way. So consider integration of COVID-19 vaccination into existing service delivery and explore partnerships with private sector to improve transport, for example, providing travel vouchers. So by adapting services to women needs, we are ensuring better services provided, and therefore we are improving experience, building trust in healthcare workers and health services. To improve experiences of care, we also need to ensure health workers training and preparation so they are equipped to provide all the clarifications, address questions, queries, and improve the experience. And finally, we need to ensure adequate M&E frameworks and commit to obtain gender disaggregated data for priority health indicators at both national and local levels. Next slide. Next slide, please.
You don't see it?
No, maybe it's on my side. What you see is the slide about South Sudan?
Oh, yes.
Okay. Oh, now I can see. Thank you very much. So this slide provides a country experience showing how evidence-based intervention can contribute for equitable vaccination, scaling up COVID-19 vaccination among women. South Sudan is one of the countries in the region facing gender-related challenges. And here UNICEF supported quantitative and qualitative research using human-centered design approach and behavioral and social driver surveys to understand the whys hampering the uptake in regions with low performance in order to better inform planning and decision-making. Some of the key findings are in line with the regional trend that women trust less in vaccination, they are more hesitant, and face more access-related challenges than men. So based on these, we developed and implemented some of the programmatic recommendations that I already presented in the previous slide, alongside with a strong evidence-based advocacy for outreach sites beyond the fixed point was also made, and other activities such as radio talks with two-way communication, tailored message, but based and informed by the qualitative research about gender relation issues and a robust community mobilization. And the implementation of those interventions was critical to increase uptake among women from 26% in September 2021 to 48% in April 2022. Next slide, please. I cannot see, but I assume that
yes, it's
on my side, probably. Exactly, key takeaways.
Yes.
Thank you. The final slide is to highlight the importance of social and behavioral data to inform planning and decision-making to contribute for equitable vaccination. Social sciences and qualitative research are needed to understand and provide evidence to address disadvantages and to uncover the root causes of inequity. We need to understand where inequities exist, but also who they affect and why they exist. We need to ensure time series data collection to understand social and behavior change. We need to obtain disaggregated data by gender, by sex, by priority group, but we need to go further because women are not an homogeneous group. So we need to know profiles considering specific contexts, specific challenges, perceptions in order to customize interventions to be more effective. These allow us to reach subgroups with tailored interventions. And finally, invest in trust and self-efficacy. Ensure evidence generation and use of data to inform planning and improve access. This can provide an important contribution to achieve the goals of high and equitable vaccination coverage. So I will stop here. Thank you very much for listening. Over.
Thank you very much, Carla. The floor is yours.
Yes, thank you, Alex, and thank you, Sofia, for that presentation. My name is Carla Toko, and I'm the Senior Manager in Advocacy and Communication for VillageReach DRC. And our presentation is just to share really the experience of us running a high volume vaccination site and how we were able to address the gender disparity in COVID-19 vaccine uptake. Next slide, please. So DRC introduced the COVID-19 vaccine back in April 2021. However, within a few months of implementation of introducing the vaccine, DRC still had one of the lowest vaccine coverage. So through November of 2021, we had less than 1% of vaccine coverage. And with a focus in Kinshasa, particularly where most of the COVID-19 cases were, we still had, DRC still had a very low uptake among the population. And as you will see, about 12,000 were completely vaccinated. And there were many reasons for that low uptake, some of which have actually been covered in Sofia's previous presentation. Next slide, please. And so, VillageReach is an organization that's been working in DRC since 2015. And our mission is to transform healthcare services to reach everyone. And one of our approaches is actually to make sure also the health products, particularly vaccines, reach people where they are. And in our support to the Congolese government through its EPI, we were able to launch a high volume vaccination site in Kinshasa on November 29, 2021. And this was really to support the government's action. As in the beginning, there weren't too many vaccination sites. And through these vaccinodromes, we wanted actually to reach a great number of people, not necessarily in a hospital setting, but mostly in highly frequented public spaces. Next slide, please. And so within the first few weeks of opening that vaccination site, we encountered many challenges. So even though on average, our daily average was the highest among the sites in Kinshasa, we were still far below our target of reaching 1,000 people per day. And then eventually also the numbers showed that there were significant gender disparities once we compared even to the national or even provincial figures among the vaccinated. And so by December of 2021, so roughly a month into running operations in these vaccinodromes, of all the vaccinated people, women only represented 20%, whereas the national coverage at the time was 38% for women. Next slide, please. And so in seeing those gender disparities, we relied on a lot of contact with the clients who were coming to get vaccinated to a vaccinodrome, either interviewing them or even through exit surveys that we were running, and also relying on other partners who were doing surveys to really figure out what were some of the barriers that were, driving these gender gaps in terms of vaccine uptake. And so there are three main areas that we identified. So one was hesitancy, and women who were thinking about getting pregnant or those who were breastfeeding had lots of concerns about the COVID-19 vaccine, especially in the beginning too, where the guidance on that weren't too clear. And women also expressed challenges to getting to the sick site. So taking into account what most Congolese women do. So a lot of them are in the informal business, and a lot of them also sell in the market to make ends meet. And so, so they express a challenge in terms of leaving their homes or even leaving their workplace to make it to the site to get vaccinated. And lastly, in DRC, the pregnant women are, well, at least for them to get vaccinated, they require a doctor's note. So, and this is really part of our national guidance, where it requires women to see first their doctor to get a note before they get vaccinated. And unfortunately, in our site, we've seen pregnant women come, but unfortunately, we had to turn them away because they didn't have a doctor's note. And very few of them actually come back once we do that. And so then those barriers really showed us that we needed to come up with strategies to really address access issues to the vaccine and also on the demand side. And so as it relates to access, it was mostly making sure that vaccination will be more convenient to women. And also on the demand side, really making sure that through health workers who are working in the vaccinodromes, community health workers, and also our own efforts to sensitize women in various settings, that we will be able also to address some of the questions that they had about the vaccines and really encourage them to get vaccinated. Next slide, please. And so as it relates to access, so overall, we went from between November and April, we went from 1 vaccinodrome to 4. So our initial one was really only located in the central district of Kinshasa in the Gombe district. However, as more time went on and as we heard more issues of people really getting, expressing difficulties making it to the central district only to get vaccinated, we decided to open 3 others in various parts of Kinshasa in very distinct areas too. So we have one at a transportation hub of Kinshasa. We have another, a third one at one of the most popular markets in Kinshasa, and then a 4th one in another populated area of Kinshasa as well. And by expanding the number of vaccinodromes, we also wanted to use those vaccinodromes as hubs for more outreach vaccination. And then the location will also be decided amongst the health workers, the community health workers who also know really well the areas, and eventually even community health workers will help us to do a mapping of the women's associations that were represented around our vaccinodromes. And then some other things that we did to really address gender-specific barriers was also to make sure that our outreach teams will also go where we could easily find women. So whether it be at the workplace, at the NGO offices, or even in the marketplace where we can find them. Next slide, please. And then as it relates to demand, so as mentioned, we're working with a set of community health workers in our vaccinodromes, and they really help us to sensitize and provide much needed information on COVID-19 in the surrounding areas of the vaccinodromes. And so we had to also do some shifting in some of the modules that were produced to support that sensitization work, whereas we would ask them to even, have that conversation, more conversation with those who are interested, or those people that they meet, so that they will better also understand what could motivate them to get vaccinated. And then the other thing that we also did is to have community health workers pre-register people for vaccination, so that once we have a set number of people who are pre-registered, then we can also organize outreach to those spaces. And for those who can come to the site, then we provide specific tokens, so that we will also know people who've been reached or referred to the site by the community health workers. And other gender-specific strategies we put in place to address those gaps was to also even out the distribution of male and female community health workers, where we thought that maybe another woman would be more attentive or more accepting of the information that's coming from another woman. And lastly is also group sensitization. So this was really a perfect setting for us, whereas we will contact women who are in different associations, in churches, NGOs, to also organize sensitization sessions, where it will be also a space for women to not only hear from us, but also have them ask any questions that they would have about COVID-19 vaccines. Next slide. And so over time, we've seen how those strategies have helped us increase the proportion of women vaccinated against COVID-19 amongst our various vaccinodromes. So we really went from 10 in the early days to now 40%. Next slide, please. And this graphic just is really showing really the difference between men and women who are vaccinated through our vaccinodromes. Although there's still some gap, but there's really been a lot of improvement in the past few months since the month of February. Next slide, please. And so for us, we've just learned that it's important, in order to really close that gender gap, to increase COVID-19 vaccine uptake for women, it really requires to increase convenient access to vaccines. And so our teams really had to be flexible, adapting to our settings, and also really communication between community health workers and the site managers, to help identify places where we can reach out to more women. And then obviously it also required us, as the next point says, to also multiply our outreach sites. And for us, the next step is to further target our outreach to the mapped women's organizations that we have, for all the organizations that are around our vaccinodromes. But also we're in the process of integrating the COVID-19 vaccination service within immunization, where we feel that that's also one opportunity for us to be able to reach the women. So here in the Congo, it's mostly women who bring children through routine immunization sessions, and we want to take advantage of that time as the women are coming with their children to be vaccinated, that they also would be sensitized and counseled on the benefits of getting COVID-19 vaccination, and that during that same day, they can just go next door to receive the COVID-19. And so next slide, please. And so that's the last slide. And thank you so much. And I'll be able to respond to any questions.
Thank you very much, Carla. Stephanie, would you like to take some questions? I see there are like 2 questions.
Yes, sure. And of course, if anybody wants to ask a question that isn't in the chat already, I don't know if there's a hand raising function, but we can also do that as well. We have a little bit of time. So yes, thank you to those who had put questions in the chat. So the first one, very, very good question, Nessa Ryan. What has been presenters' experience when engaging with partners who may be skeptical of gender barriers, or even those who do not value or prioritize gender responsive programming? What do you say to those who perceive these approaches as challenges to their culture? So it's a super simple question.
Yes.
No, it's a very, very good question. And I'm really interested to hear what Sofia and Carla have to say, because they have a lot more direct interaction with the country offices and teams. I'll just say one brief thing from the global perspective, and that's just that even the concept of gender issues with immunization has historically been met with some resistance, because the reaction, and I'm talking mostly about routine immunization, but you could say the same thing about COVID-19, since the data, as I showed globally, looks like, oh, there's not really much of a difference in coverage. And we know for routine immunization, for many, many years, we have pretty equal coverage of routine immunizations between boys and girls. And so the reaction is always, well, there isn't a gender issue in immunization, but of course it's not true. And of course it's all of the underlying barriers that might actually be impacting access to services in the first place, which means these figures are not showing up in the coverage data. It's actually those who aren't accessing immunization where a lot of those problems really are. And so it has taken a little bit of time to change the reactions around with a lot of people who actually work in immunization, to even open up their minds to thinking that there are potentially gender barriers that are impacting access and uptake of these services. And so it's been a bit of a process to change that. But the second step of, once these barriers are identified, but they're systemic issues, often deeply embedded in cultural, socio issues, how do you change that? And that's obviously not an easy one. So I'd love to hear, Sofia or Carla, do you have any experiences in your interactions with partners on how they've handled this?
Thank you very much, Stephanie. I can just provide some. We are supporting country offices, and that we are not implementing, but the implementers, the partners, to start, I would say, start with your own organization to ensure that all the team and ensure that all programs staff are really committed with gender equality and gender transformative program. Although I think the data is really the key to use in different layers and different steps in different phases. So using evidence. So, hello?
So Sofia,
Yes.
your connection is a little bit unstable. So perhaps if you could repeat the last 2 sentences, because you were cut off. Thank you. Sorry about that.
Maybe no worries. I can also put in the chat if it's better. So Carla can proceed if you cannot hear me well.
Okay, thank you. Perhaps Carla, you have something to add?
Yes. So I'll say that in DRC, I haven't noticed any skepticism about addressing, gender barriers or the gender gap that we noticed. So it actually felt like COVID-19 vaccination even helped us to even track, the difference in uptake between men and women, whereas it's still we're still lagging behind for routine immunization to do that. So that's one thing. The second thing I remember in the very beginning, when it was initially introduced in COVID-19 vaccines were introduced in DRC, that in the coordination meetings, we actually spent a lot of time discussing why there was such a gap between men and women. So, it's been, I would say that discussions in DRC has been positive in the sense that we've had discussions on actually trying to actively reduce the gender gap, and many other partners have even are working with local organizations, network of women in which they've trained, and are also supporting to sensitize women within their network. But maybe one thing that remains is, as I mentioned in my presentation, the guidance for pregnant women, whereas in other countries, pregnant women it's already being accepted without a doctor's notes, because we assume that the woman has already had conversation with her doctor before getting the vaccine. So maybe in terms of that policy, I think eventually in the coming months, the EPI and the government will probably try to reverse that guideline, whereas women can easily now walk into any vaccination site to get the vaccine. But we've been really discussing in DRC ways in which we can reduce those gender barriers.
Thank you, Stephanie.
Great, thank you. And so we do have one more question from Nurdin Kadyrov. Is there any disaggregation by education, income, or rural versus urban? So I can speak to what kind of data we're collecting at the global level for vaccination coverage. And of course, what we're able to collect globally is obviously limited, and we really rely on country reporting. And so what we're doing is we're tracking sort of the big buckets. We are trying to track gender disaggregation, but as I said, even that is so limited. We only have 84 countries out of 194. So it's less than half that are reporting this data. We're tracking the coverage of target priority groups. So for example, health workers and older age groups, and we're tracking coverage with adults with comorbidities, but we're not we don't have data at the global level disaggregated by things like education, income level, et cetera. These are the types of things that the ability to disaggregate data at that level is obviously more relevant at the country or mostly subnational level, I'd say, so that that's where the data would be available. And it's absolutely important for programs to be trying to disaggregate whatever data they have to help identify where some of these issues might be cropping up or barriers. Some of the tools that I shared in my presentation, for example, the behavioral and social drivers, vaccination tools, those are questionnaires that are meant to be carried out in a targeted way. So either at a community level or a sub-regional level, and then that will pull out some of these discrepancies within some of these disaggregations that you're mentioning. So it's really about countries taking ownership to try to get the data that's applicable to their areas and be able to identify the barriers that way. Sofia and Carla, do you have any information? I don't know if you're collecting any of that kind of disaggregated data at the regional level in ESARO, Sofia?
Thank you, Stephanie. Don't know if you can hear me.
Yes, I can hear you
see
now.
that my connection is unstable, but okay. So we collect data on SPC on social and behavioral data. So yes, we collect disaggregated data and we advocate for disaggregated data all the time by sex, by age group, by priority group. So we have been collecting by locations also. So I saw also a question on rural and urban. So we have been collecting across all the countries in ESARO that are introducing COVID-19 vaccine.
Thank you. It's actually 4 o'clock. Maybe you have 1 more minute if anyone would like to add something on this topic. No?
I don't see any hands raised either.
Okay, great. So I think we can wrap up this session. Thank you very much. Thank you very much, Carla. Thank you very much, Sofia. And thank you very much, Stephanie, for presenting this. We're going to share this this presentation, the video, with everyone. I wish you all a very nice day, and we hope to see you next week at the same time for the next session. Thank you, and have a great rest of the day. Bye-bye. Bye, everyone.
Thank you all. Have a good day.
Thanks, everyone. Bye.